Thank you so much. And I'm really excited to have the opportunity to talk to my UCF colleagues and just based on my colleagues that were just presenting to get a look at the diversity of research that UCF offers. So yes, I'm an assistant professor in the School of Global Health Management and Informatics in CCIE at the downtown campus. And the majority of my work focuses on this broad topic, and I'll talk a little bit about how I look at that in different contexts. Armed conflict is a determinant of health and well-being. So just to briefly tell you about myself, I am a two-time UCF alum, a master's and PhD at UCF. I've had 30 peer-reviewed publications on this issue, a Fulbright scholarship to study health in a fragile context. Unfortunately, because of the frequent topical nature of my work, I've had the opportunity to be on major news organizations and write pieces for the New York Times, the Washington Post, and others, have done congressional briefings, just published my first book in January 2024, aptly titled How War Kills, the Overlooked Threats to Our Health, and was just recently awarded through the American Public Health Association, the Victor Seidel and Barry Levy Award for Peace. So I fit my work into three major areas of focus. The first is the broad issue of health and human rights in fragile and conflict-affected populations. The second is gender and global health, and this is both gender in terms of women patients and the challenges that they face specifically in fragile contexts, low-income countries, but also women in healthcare workforce. We know that the vast majority of healthcare in the world, up to 70%, if not more, is conducted by women, and yet women are featured on an unrepresented proportion in global health leadership. And then social and political determinants of health, primarily in global contexts, but also domestically as it relates to substance use disorder and other issues in the US. My research approach, because of the really varied nature of my work, is also quite varied. So I utilize mixed methods, so quantitative and qualitative, and of course, studies that utilize both. Especially when I'm able to do international field work, I always like to include qualitative interviewing, focus groups. And I feel that that really enhances the richness of this work because when you're just looking at statistics about these contexts, you can really miss a lot of the nuance about how this influences people's lives and their health and their choices that they make with regard to their health, et cetera. Because this field as a whole, kind of humanitarian health or war and public health, is very it's relatively new. So the first major academic book on this topic came out in the mid-90s. And so there's still a lot that we don't know about these contexts. One, because there's little funding specifically to study them. Two, because as you can imagine, studying them is difficult. They are inherently insecure. They're hard to get to. The populations are hard to get to. The populations are also often not trusting of giving accurate information. And it's very easy to mix causes. So when you look at a context like this, it's easy to say, well, this is a low-income family. They can't afford healthcare or they can't afford pharmaceuticals. But when you step back as to why are they low income, and then you look at the societal causes, that can give you a very large picture. So a lot of the work is also still gathering what we have already know, the evidence we've already seen in systematic and scoping reviews. Much of my fieldwork is international, and I'm very fortunate because this work kind of straddles so many disciplines to have had really wonderful interdisciplinary collaborations at institutions around the world in the fields of medicine, law, anthropology, economics, political science, and health informatics. And this is a sense for how diverse this work can look. So these are just some of my publications from the past few years. One is looking at women in the workplace in low-middle income countries and how we can promote their ability to work with health information technology, or rather asking, can we? Is this an appropriate use of technology? The second was assessing gender responsiveness of COVID-19 response plans in settings of conflict-affected populations. The third is more topical, looking at civilian mortality and damage to medical facilities in the current war in the Gaza Strip. And then the last article is a commentary about how freedom of movement should be seen as a determinant of women's health, especially in societies where that movement is limited. So the project I wanted to specifically bring to you today is about, this is my most highly cited piece probably, and it's about looking at and questioning the role of digital health in making progress towards Sustainable Development Goal 3 in conflict-affected populations. So I'll back up for just a second to tell you that the Sustainable Development Goals are the global development agenda set by the United Nations, and they do it in decade periods. So there was the Millennium Development Goals that started in 2000. Now we are in the Sustainable Development Goals. And the Sustainable Development Goals were meant to learn from and build upon the Millennium Development Goals. Now, these goals are wide ranging. They're on education, they're on infrastructure, they're on poverty, and there is a specific goal for health and well-being. And so what we were looking for in this study is we know that conflict-affected populations need support the most. When we look at a society like the US, often we're spending a lot of money getting people with good outcomes to great, and you can spend a ton of money trying to do that. But we would see significant progress if we could get people with really poor outcomes to good outcomes. And can we use health information technology in these settings of physical insecurity, of poverty, of patriarchy, where women may not be allowed to leave in certain settings or serve as physicians? How can we employ health information technology, digital health, to support these populations? So SDG 3 prioritizes health and well-being. However, we feel, and the data is bearing out as we speak, that we will not meet many of the Sustainable Development Goals in conflict-affected populations without a specific focus on their needs. So what we've done is we've given every country the same measures, but these countries are the furthest away from them and thus need the greatest help to get near to them. So to meet these ambitious health goals, digital health can help to bridge healthcare gaps. So this paper was published just before COVID, which, as you can imagine, is not a great time to be starting a global health project that probably requires some travel. So we paused it temporarily in terms of progress, but we were really looking at how we can apply, especially looking at things like telemedicine and telehealth, cell phone applications. We've seen pockets of innovation here. So for example, in some countries, there are apps where women can download them discreetly and learn about domestic abuse and report, or women can receive kind of specialized care from an OBGYN in another country via chat. They can talk about their symptoms, etc. They're not perfect systems and they're not replacements for healthcare systems that work, but can we fill in some of these gaps? So what we had originally planned to do was apply to an NIH grant about developing an mHealth app that we posited would be supportive of populations who either cannot or are fearful of traveling for healthcare, either because the facility is too far or because they live in a setting of active conflict where the facilities may be destroyed or there's too much insecurity on the way. As you can imagine, there's a lot of challenges and problems to doing this kind of work. These settings are inherently fragile and vulnerable. Populations have little sometimes or no internet access or electricity, so we were looking at workarounds with that. There are very little good data out of these countries in terms of health outcomes, period. So how do we see what these populations need when we don't have great data about what's already going on with them? Again, they're hard to reach. There's lack of trust often with international researchers, and there's a whole host of other ethical and moral questions when dealing with these kinds of populations. So in the war environment, there are multiple threats to health. So not just, of course, battle-related trauma, which is what we typically associate with war, but as we see in many of today's wars, food and water insecurity, spread of infectious disease, environmental exposure from munitions or from the destruction of water treatment facilities and power plants and other things, enhanced risk of non-communicable disease spread, especially as people are kind of in overcrowded and underserved shelters. And perhaps the least studied of all is the mental health toll of all this. So even people who escape with their bodies intact, we know that they are leaving these settings with significant mental health barriers that prevent their ability to work, to study, to engage with their lives. There are, of course, special considerations for refugee and internally displaced populations. And I think we also can't forget that within this broad umbrella is the health of service members and veterans, which we do a good job of studying in this country, but is very poorly understood overseas. And as we know, there are significant gaps to this care in the United States. In terms of short-term goals, I'm applying for a NSF security and preparedness grant about measures of indirect deaths, indirect mortality in war zones. So we're really good at counting battle-related traumas and injuries. We're not so good at counting, even still, people who do die from infectious disease or untreated heart conditions or et cetera, and so on. And so this is my project for this year, and continuing to seek collaboration with interdisciplinary colleagues, including perhaps some of you. In the future, I would like to get back to that NIH mHealth grant, as well as external funding for, now that we can travel again, a cross-border study of social determinants of health in areas of conflict, and write a second book, but I might wait for after tenure for that one. And I would like to open to any questions. Thank you for your attention.